Okay.
Good. Hello, everyone. This is Dr. Shaher Khan. I'm a board-certified plastic surgeon, and it's a pleasure to talk to you today about what is a very important topic, breast implant illness. So I want to go ahead and I get this question asked a lot. I live out of the state. I'm in a neighboring state. I'm in California. I've had a lot of patients that come to me from all over. Is it safe for me to travel? Is it safe for me to get the surgery done and then eventually fly back? So I'm very happy to state almost 2/3 of my patients come to me from out of state. This is from California, Texas, New York, and almost every state of the United States. I've had patients from Canada, from Mexico, from Jamaica, from Egypt, from India. I have patients that have come to me all the way from Hawaii, from New Zealand, Austria, Germany, Japan, from England, and Italy, and so the Iran. And so the point here is the patients come to me, I've already talked to them, they have been to my Facebook page, and they have also been to my YouTube page, and they have learned a lot more about why I do it, how I do it, in the manner that I do, so that when they come to me, they are not only prepared, but they're also very excited about their surgery. Now, as they do come, the surgery gets done on a Tuesday in a very defined way, or Wednesday, and then they recover the 2-3 days. And when I do see them on the Friday, they eventually meet criteria to be heading back home safely. And this is where I can then follow them very definitively, completely from the comfort of their own home, so that they get the same post-op follow-up care like someone else from the United States or from Michigan would. Now, it is very safe to travel, very safe to get on the plane. Patients ask, what are the risks for clots? I just want to go ahead and mention on the day of the surgery, every patient gets a heparin sub-Q 5,000 units shot. This is for DVT prophylaxis. I have my patients out of bed to a chair the day of the surgery. The following day, I have my patients up and walking about, walking. So that prevents any clot formation. Number 4, I also have my patients get what is twilight anesthesia, which is propofol, fentanyl, Versed. The patients are not paralyzed, they're not put on a ventilator, and so the chances of getting clot are essentially minimal to non-existent. So these are the preventive measures. Some patients, especially if they're going to do the long trips, this is what they should be doing anyways. They can get compressive socks, garments, which they can wear, that provides for some reinforcement, which are the compression socks. Last but not least, every single patient on my operating room table gets the SCD boots, which are the sequential compression devices. So overall, very well tolerated outpatient surgery, and this is a surgery where if a good preoperative workup is done, the intraoperative and postoperative course is very predictable and very benign and very smooth. Now, I want you to please go ahead and ask me any questions you wish, anything pertaining to the surgery, so that I can help you understand how and what my technique is and why it is important to undergo each one of these parts of the procedure, so that you get a full comprehensive workup. If you had your surgery done today, for example, you would have that peace of mind. All of that capsule was removed completely, definitively, sincerely. If it is below the muscle or above, the entire capsule is then sent to pathology to make sure there is no the BIALCL, which is the very rare lymphoma, the very rare squamous cell cancer, and that a complete workup is done to make sure there is no abnormal pathology, no malignancy associated with the capsule, and also the microbiology is sent to the microbiology lab for aerobic, anaerobic, and fungal cultures. Now, these are 2 aspects of what is the Khan procedure. The other things is that I do what is the twilight anesthesia that I talked about. That's number 3. Number 4, I return the implants, be it saline or silicone, back to the patient, so they can basically confirm that this was the card that they have, this was the implant that they had. Number 5, I do basically high definition pictures and videos of the chest, showing complete removal of the capsule. Remember, this is a surgery that normally takes 4 hours on average for average size implants. And so 2/3 of the time I go over what is the allocated 4 hour time. And remember, this surgery is all about precision, about accuracy, completely removing the entire implant and the capsule completely sincerely off of the rib, such that there is no capsular burden left behind, and that there is no inflammatory burden left behind, and that all of that abnormal tissue is removed and tested. Number 5, I want to mention, this is majority of the patients do very well without the unnecessary lift. And this is a surgery where you should not do a lift, especially at times, even if you have 800, 1200 cc implants, because that may lead to nipple and skin necrosis. Number 7, I basically do not use drains. I've not used drains in any of my patients in the many ruptured implants, large implants that I've done in well over 5 years now, since 2019. And last but not least, all the patients, regardless of their age, comorbidities, be it cancer patients or cosmetic patients, they basically get the same surgery, so that I do not compromise or leave capsules behind. Remember, the whole goal and gist of the surgery is to remove the entire capsule completely, definitively, along with the implant, in what is the en bloc fashion, without leaving behind any of the capsular fragments or inflamed tissue. Just today, I saw a patient, the pathology came back where that inflamed tissue around the capsule was indeed lipoma, or the other patients where they have had fat necrosis or neuroma or fibroadenoma that I've encountered in the proximity of the capsule. If I find any abnormal mass in the proximity of the implant capsule, I will certainly remove it, so that we can get to the bottom of it. You do not want to leave anything abnormal or bad behind. Now, please ask me any questions, and I will take this as a chance to go ahead and answer any additional questions you may have.
One of the TikTok followers asked, what is the trifecta cocktail for sedation for anesthesia?
Sure. So this is where, let's talk about the twilight sedation: propofol, fentanyl, Versed, and I also give a local nerve block, which is lidocaine, epinephrine, and marcaine. And this is where, for the first 6, 10, 12 hours after surgery, the patients are basically have a good nerve block, just like when you go to the dentist. The patients are not paralyzed. The patients recover relatively well, because there is no general anesthesia, and it is very adequate, practical, very user-friendly anesthesia, and this is where the patients recover optimally. To date, not a single patient has had any recollection of their surgery or remembered any conversations within the OR. This is more for the movies. Now, the general anesthesia is where you have to be paralyzed, and now you cannot breathe because the muscles are not involved in the breathing. Then the breathing tube is put in, and this has to be done relatively fast. This is the general anesthesia. And now the ventilator is essentially breathing for the patient. This is required in those surgeries where the patient's going to get gallbladder surgery, and you want to paralyze the patient so you can put the air into the abdomen, so that you can dissect laparoscopically, or someone who's getting, for example, back surgery. But for explant surgery, twilight sedation, deep sedation is very safe, very effective, and gets the job done with minimal risk to the patient. Remember, when someone gets paralyzed with general anesthesia, the muscles are paralyzed, and now the blood can pool in the leg and clots can form. Or if the patient's on a ventilator for long periods of time, there might be some ventilator associated trauma that indeed can occur. But again, very well tolerated general anesthesia. The twilight deep sedation is even better, safer, more practical for what is very well tolerated outpatient surgery.
And then another TikTok follower asked, why don't you like to use drains?
So I don't like to use drains for many reasons. First of all, let's go ahead and talk about the proof. I have done thousands of explants where the drain use has not been there, to the point where last year in May of 2023, I presented my 1,000 explants, and I said I needed drains in only 7 of my patients. This is the many ruptured implants, large implants. Even the 1200 cc implant that I removed, I did not need the use for drains. Blood loss is less than 5 cc's in well over 99.5% of the patients. And then the dissection is done in a very nice avascular bloodless plane, such that all bad tissue, inflamed tissue, is removed leaving behind all good healthy tissue. So there is no requirement for the drain because there is no inflammatory burden left behind. And this is consistently being proven. And as you will see, my patients have not come back to me or have gone to other doctors where the drain was placed or the drain needed placement or they needed to manage what is fluid that accumulated in the chest or the breast. Now, if a surgeon is rushing through the surgery or they're just cauterizing that capsule, which means that the capsule essentially remains behind and part of it is just burned off, or if the silicone spills into the chest, or the surgery is done in a very awkward, haphazard, rush through manner, now the drains becomes mandatory. And this is where you will see the unfortunate use of the drains not only in 1 week, 2 weeks, but 3, 4, 5 weeks out, which is in itself can be problematic. The drains themselves can go in and out of the chest and seed the bacteria that's on the outside of the drain inside as the drain moves in and out. That can happen. Sometimes if the suction opens up, the fluid can drain back into the chest. That can be a catastrophe because what is in the drain is not necessarily sterile or bacteria free. And remember, the drains themselves also induce fluid formation. And so this is where clearly, as you can see, the burden is on all those surgeons who are using drains. And why is it that I'm not? Because it's not required when the surgery is done completely, definitively, sincerely, in a very nice, controlled, precise manner over 4 hours, where the bleeding is minimal and no inflamed tissue remains behind. And this is certainly done very well. So in some of my patients where I used a drain, was an 81-year-old lady. She was involved in a car accident. And as soon as I made incision, there was free floating silicone from the early 80s that she had from a silicone implant. And because of the car accident, her chest and the seat belt and the steering wheel, the way it affected her chest, the free floating silicone was there. So now the silicone was already free floating. There was no way that I could do it en bloc, and now the patient actually needed the drains without any doubt. And so she did end up getting the drain, which she did very much need because of the way the silicone had spilled into the chest. Another similar patient where she had, as soon as I made cut, the silicone was pouring out because there was an extra capsular rupture. She had trauma to her chest, and now as soon as I made incision, her left side absolutely needed the drain because the silicone had spilled under the left chest and the drain became mandatory. So hopefully that answers your question.
Okay. And then another TikTok follower asked, do you offer stay accommodations for out-of-state patients?
So for out-of-state patients, I tell the patients, if you go to my webpage, executiveplasticsurgeon.com, you will see a list of hotels, Airbnbs in the area where most of my patients come and stay. So you can please go ahead, and if you have any points or any other big hotel chains that you're contracted with, you can certainly stay there at a relatively speaking discounted rate, but that should help you in regards to any stays around Bloomfield Hills address where I am, so that you don't have to drive much when you do come and see me at the hotels. So majority of the patients that do come, they basically come and see me. So today's patient, an hour ago I saw her. She came from Alaska. So she would come in today, and I've seen her pre-op. I've examined her. We have gone over the discharge instructions. I've given her the medications. So she's going to stay here Monday night, and then the surgery happens tomorrow at early in the morning, and then she recovers Tuesday, Wednesday, Thursday. I see her again on Friday, and then Friday she would essentially meet criteria to be heading back. So this is essentially going to be a 4-night stay for her. So when she heads back, she has that peace of mind and the confidence. When she heads back, I will be able to easily manage her definitively, completely from the comfort of her own home.
Okay. And then you mentioned your website, but what's your website address?
Sure. So the website address is www.executiveplasticsurgeon.com. I want you to please join my YouTube page as well, where you will have almost 550 videos as to how I do it. A lot of interviews with former patients, other clinicians like pulmonologists, cardiologists, pathologists that you will find very useful. Interviews with Dr. Henry Dykman, for example. I have lectures that I've given. You will see a lot of Facebook lives and YouTube lives directly. Another very important page is the Facebook Private Breast Implant Illness Support Group page by Dr. Khan. Please become a member. This is a private group, and this is where you not only have your freedom to see what goes on in this private group, but also to discuss and share your questions, thoughts with other former patients of mine so that you can get the questions answered. There is no other better way to get your questions answered is to certainly talk to me, but to also talk to the former patients so that you feel comfortable and you have firsthand direct feedback from the patients as to why I do in the manner I do, the complete transparency, so that as you come in, you understand what you have signed up for, and this is truly what is informed consent.
Are all follow-up appointments via telehealth if you are out of state?
So the first one is the usually 3 days out or 2 days out from the surgery. If you are out of state, then depending on your convenience, you don't have to come. There are patients that live an hour away and still choose to do a telemedicine because I'm able to answer their questions in a very defined, definitive way without having to do an in-person clinical exam.
Is there any reason that anyone would have to come back for follow-up appointments if they are out of state?
So there is no reason. This is where the surgery can be done completely, definitively, and the post-op care can be done in a very defined way without having to do an in-person exam. So I have not had patients come to me for any follow-up.
Okay. Is there any like wound care or dressings that I need to do for after surgery?
So when you have had your surgery done, let's say on a Tuesday or a Wednesday, I will discharge you back home such that the following week at day 6, 7, or 8, I will then have you remove the tape, and that would be your next or your first dressing change. The first one would be, or first time I will look at the wound is going to be on that Friday. The following week when you're home and your significant other is there or friend, then you would essentially remove the tape and then take your first shower. This will be around day 6, day 7. And then you start doing what is the regular bra and binder, putting that on. So there is no dressing changes per se, no wound care that needs to be done. Because when you remove the tape, essentially you're moving on to the next level. There is no dressing change that needs to be done.
A patient is wondering if they can do in-person follow-up if they want to.
Absolutely. So any patients who wants to follow up, they're more than welcome to come and follow up with me in clinic. Just today I had a patient, she does not live far away. She called and she wanted to see me because of a rash, and so I was able to absolutely see her. Literally I asked her to come in right away, and this is how I'm able to manage and see my patients. As you will see, I'm very much hands-on before pre-op, during the initial phone consult phase, during the pre-op clinic, intraoperatively and post-operatively. You're going to directly be talking to me post-operatively. Only I know what happens and what happened in the operating room, and only I will be able to direct you post-operatively. One side may be different than the other, and I determine the post-operative course from case to case, from one side to the next.
Okay. After surgery, how much weight can I start lifting, and when after surgery can I start lifting?
So post-operatively, as you will see, the majority of the implants are below the muscle, the pectoralis muscle, which sits on the chest. And the entire surgery, if the implant is below the muscle or even above, is done below the muscle or above the muscle. Now this muscle needs to essentially settle. So just like after a tummy tuck, you're not going to move around right and left and twist and turn and do exercises. Likewise, post-operatively, post-explant, you want to keep your elbows towards your side. What the ladies talk about is the T-Rex arms. You can type, you can text, you can make yourself a sandwich, make a cup of coffee, no problems. You can do your desk job, but you cannot lift a gallon of milk. You cannot hang your coat. You cannot work as a nurse, for example. And so essentially you recover relatively well. As you will see, a vast majority of the patients, 2-3 days is how long they need the pain medications. after 2-3 days, the pain medication requirement goes down significantly. And then I wait essentially the 6 weeks for the muscle to settle, such that now at the 6 week mark, most of the patients, I have them now starting to lift the 2 pound weights. So they will flex and extend, do the bicep curls, do the neck, back, shoulder, gentle exercises. And remember, all dictated by me, such that not in 1 month, 2 months, but 3, 4, 5, 6 months, they will be able to add muscle mass not only to their chest, the pectoralis major, underneath which majority of the implants are, but also the pec minor, the serratus, the latissimus, the deltoid, the suprainfraspinatus, all the muscles of the neck, back, shoulder, such that your athletic ability which will be much better and enhanced and improved now that the inflammation is not there, the fibromyalgia type symptoms that the patient do have them is not there, there's no mass getting in the way, and there's no strain on the neck and back as a result of the weight of the implants. And the patients certainly are able to not only improve their muscle function, but their posture also is improved significantly now that they don't have to carry the relatively heavy burden of the implants around.
How can I cope with any changes in my body image after surgery?
So this is a very good question. This is certainly a change back to where you were before you had your implants. On the day of the surgery, when the explantation is done, you lose not only the implant itself, size and volume wise, but you also lose some of the very small amount of capsule that's around, plus the inflammation that subsides. Now, between me removing the excess skin at the bottom, and when you do join my Facebook group or my YouTube page, you will see what I'm talking about. Only the horizontal incision that is made in order to remove that excess skin between the internal sutures that are placed that lift the breast tissue up and towards the midline, between the gravity of the implant not pulling the breast tissue down, between the recoil of the skin and the breast tissue, and between the 5, 10, 15% muscle mass you're going to add to the chest, you will see a majority of the patients do not need what is that unnecessary lift. Now the volume certainly will be back to where you were. Now some patients who had a augmentation done 20 years ago, 15 years ago, as you will see as we all age, most of us do put on weight. Sometimes that fatty tissue masks that loss of volume. In some patients, you will see they will have had significant loss, for example, if they have 500-600 cc implants removed. Now, one has to be wary of the fact that this is certainly very much going to happen. If you have, let's say, 100% of the chest breast volume of the implant that is on the chest, and you remove, let's say, 50%, now 50% of the volume is reduced. And remember, the whole surgery, if the implant is below the muscle, is the volume that is removed below the muscle. The breast tissue above the muscle is not touched. So you're going to be back to where you were before. So if you remove 50% of the volume, you're certainly going to be left with 50%. And this is sometimes for some patients not a pleasant change, especially when they're used to larger volumes. This is where you have to have that support at home, where you have to have another support, be it another patient. There is a very nice book by Dr. Amanda Savage Brown. She is a breast explant patient herself, a warrior herself, and you can see the mental, psychological ways she copes and talks to the patients and provides what I would say very genuine feedback and care that one needs to have. I tell my patients you have to be mentally ready and from your heart ready for what is a surgery, and this is where majority of the patients are not only satisfied but they're excited about their surgery because they know their good health awaits them. There is actually a Facebook Live I did with Dr. Amanda Savage Brown. You can listen to that if you go to my private breast implant illness support group page by Dr. Khan. You will see, if you type in Dr. Brown, you will see that Facebook live Facebook interview and discussions that I had with her, where I myself as a plastic surgeon benefited from what she has to say. She's truly a scholar and a gifted professional who has helped a lot of ladies over the years to help cope with this image change and the post-op mental effects of having had an explant.
What if I don't know the size of my implants or if they're above or below the muscle?
So vast majority of the patients, especially with older implants that are over 10, 15 years old, more than half of the patients don't remember the volume or the location of the implant. Now, ideally, one can get the operative note from their plastic surgeon. Now, sometimes the surgeons have retired or they've closed their practice, so it is now impossible. If you have had your surgery at a major medical center, they certainly do retain records for longer than the 7 to 10 years that's required by state law. For cosmetic reasons, these documents do not have to be saved. Now, in the world of EMR, hopefully you're able to backtrack this. The second way, if you want to find out the location of the implant, you can get basically, if you look at analyze the mammogram, if the radiologist is reading it completely definitively, you will see they will mention if the implant is below the muscle or above the muscle. So that's another way to check. So the operative record is one way. Every surgeon that operates has to have an operative record. So you can check that record. Number two, the imaging, be it ultrasound or MRI or the mammogram, if you have had one. And number three, I will tell you as I remove the implants, and this is why I return the implants to the patient, so you can see exactly what was inside your body. You have psychological closure, and that way you can exactly match what was given to you on the card. And I will tell you not only the size, but also the location, if this was above or below the muscle. So, having said this, there's a lot we discussed, and please feel free to ask any additional questions. This is my second series of TikTok, Instagram, YouTube, and Facebook Live that I'm doing. I will continue to do this now at a more defined time. I'm looking at possibly 11 o'clock on a Friday so that you can continue to tune in, or whatever times work best. This is the time where majority of us are relatively free, and we can tune in and certainly listen to it even later on, so I can answer any questions that you may have. The best way, and I'll end with this, is to be well prepared, to be well read. If you were to get your gallbladder removed in California, Texas, New York, it's done in precisely the same way. If you get your implants removed, every surgeon has his or her own way of doing it. We are not essentially taught this how to doing it in school, in our professional training. As you will see, most of the surgeons unfortunately are more fixated on the aesthetics, and deep down within there is not much consideration given to the capsule or the inflamed tissue. In this case, in my technique, as you will see, which is relatively different from the others, my whole goal and focus is in the physiologic return of the body to a normal state of good health minus the toxins, and also at the same time I measure from the nipple areola down to the crease such that I provide the best symmetry, best recoil, best aesthetic result that I can to my patients, so that, as you will see when you join the Facebook group page, most of the patients are very happy and excited without having had to do a cut around the nipple areola inferiorly, and a lot of cutting in and around the breast tissue, which I find is going to be only an issue when they do their self-monthly breast exam or when they get their mammogram, and they may lead to more scarring, hypertrophic scarring, hypopigmented scarring, in some cases very widened big scars around the nipple areola, and loss of sensation, loss of ability to nurse, and also sometimes acute and chronic pain, sometimes fat necrosis that may result as a result of extensive suturing on a time when the explant needs to be done. I love to operate, but I, as mentioned earlier, do not want to do any unnecessary surgery, especially if the patient does not require one. This is Dr. Khan, Executive Plastic Surgery.